Perfectly in time. Again, we don't know, but it show up something about it. So I think there's some kind of probably a mix of respect or he feels uncomfortable. Absolutely, as a narcissist, as a big narcissist. But I'm talking about the relationship with the UK and with the.
No, that's not.
Yeah.
No, he doesn't like us now.
Oh.
He's upset the mayor of London.
Yeah. Yeah, but not with the king. It's always like he behaves like he feels probably, you know, the tradition.
Most probably thinks he's better than the king. And by the way, I told the king about my hip, so couldn't curtsy, so you know what? He's human, lovely. He wasn't king at the time.
Il bagno è giù,
He asked me the
sulla
most
destra, nel
challenging
corridoio
question.
per entrare di là. Più o meno le spiegazioni.
Said, what do you do?
C'è un altro microfono che dove c'è il...
Ma dobbiamo metterci giù a fare libro.
But of course, his great grandma, his grandma
Ora c'è il round
was
table.
very close to
Dove c'è la cosa?
And he said, what do you think about
Minchia, si è presa sta cosa.
it's strict because I lost it. I went, oh. He said, I can see you do not approve. I said, no, I didn't say it. I said, it's such a painful treatment for some, comfort for others. He actually spoke about his grandmother. He was quite emotional. It wasn't, he was human. And it was so I had to step back. I just said,
He looks like a very clever and very emotional, passionate man.
yes, he is.
And he can be very, I mean, it's just a perception. I never, of course, it's just a perception.
No,
But
he is.
yeah, and also very much committed to really help people. So it's a real commitment. It's not done for, you know, because you have to do it or because it's, of course, it's your duty. Or
Take your seat.
which is, yeah. Please,
Controlliamo anche l'orario.
No, Rector. Buongiorno.
E voilà.
Germany, University of Siegen.
Aspetta. Guarda. Ci siamo? Okay. So, welcome everybody. My name is Simone Sarasso. I'm a communication officer here at UPO, and I'd like to thank you for being here today for today's roundtable. We will speak with several international experts about chronic wounds and a revolutionary research project in this field, INJECTHEAL, multifunctional self-healing injectable hydrogel for chronic wound healing and tissue regeneration. In this project, founded by European Union and realized in collaboration with EU Core, European Cooperation in Research and Education, UPO, has a prominent and leading role side by side with 11 international partners. Now, let me briefly introduce our guests. Menico Rizzi, Rector of Università del Piemonte Orientale, Professor Ellie Lindsay, OBE, Honorary Professor from the College of Phlebology, London. Thank you for being here. Matteo Santin, Professor of Tissue Regeneration at the University of Brighton, UK, where he leads the Center for Regenerative Medicine and Devices and serves as an academic lead for the cross-disciplinary initiative Healthy Futures. Dr. Mohammad Raoufi, Associate Senior Scientist at University of Siegen, and a recognized expert and entrepreneur in the field of wound healing, patches, and drug delivery. Elam, Sharifikulu, sorry, it happens every time, even if I trained. Assistant Professor al Dipartimento di Scienze della Salute, Università del Piemonte Orientale, and Lia Rimondini, Director of Dipartimento di Scienze della Salute and Coordinator of INJECTHEAL. Thanks everybody for being with us. Before starting our roundtable, we will have a very essential introduction about chronic wounds, and I give the word to Director Lia Rimondini.
Thank you, Simone. Not as director, but as a scientist. So, just to introduce the topic and to make easier to understand the scientific contents what we discussed today. So I would remind that the chronic wounds are a special wound that are unable to heal spontaneously and they remain unhealed for at least 3 months. It's a disease of the elderly population, and it is associated with some impairment, the vascular impairment, and immuno impairment, and that are typical related to aging. In the Western country, the wound, chronic wound is a serious disease, mainly affect the lower limbs. And so considering the elderly population, so the prevalence is about 3% of the population. And in people resident in long care residence, so the prevalence is sometimes closer to 30%. The consequences of the chronic wound are horrible because it's pain, infections, even social isolation. So from the personal point of view, is a tremendous condition. And for the health systems also, because the cost to treat such chronic patients is very huge. So I think that taking care of these special conditions and taking care of this disease is something very valuable for our quality of life. No, I don't know if it is enough for you, but I think that INJECTHEAL, if I can add something, is a project that tries to treat the condition, not just to deal with the management of the condition, and that is the value of this project that we just start.
Thanks a lot. And now, speaking about the fight against chronic wounds, I will give the word to Professor Ellie Lindsay, and that will talk about the crucial role of the leg club in INJECTHEAL and in chronic wounds fight.
Joys of technology. Good morning, ladies and gentlemen. Lia, a big thank you very much for inviting me. It's a privilege and a pleasure. I'm not a researcher, so it was all going over my head this morning. But there's quite a few correlations between all the work you do and what I do. And mine is about the hidden wound. And you're a researcher, you're in laboratories. And what is a hidden wound? I have no declaration of interest. I live in a beautiful part of England in East Anglia, famous for sunsets. However, how many of you have got a wound? How many of you sitting here actually experiencing odour, pain, poor mobility? That's a hidden wound. So many people have that experience, but they don't share it. And when they go to care in a hospital or a clinic, they see so many different people. It's a multidisciplinary approach to lower limb care. And that includes you. You're the backbone, the back door. Nobody sees the researchers. They invariably see the end product. And when I look at wounds, we haven't really moved on today. There's still absolutely thousands of people experiencing this problem globally and financially. So this is sterling work you're doing. When I look at people, there's so many challenges they're facing: disadvantage, financial, social, and most importantly, their loved ones. How many of you have thought about, when you're doing your work, the extended family? Those that care, those that love, those that see. So this is a classic wound people are living with. We're not experiencing that, are we, at the moment? And hopefully none of us will. But when you think 50% are going to have venous leg ulcers. So their experience of what their journey is critical for their story. Communication is vital, whoever and wherever you are. And questions that are difficult sometimes for us to answer, but they still need to feel part of that journey with you, because it is terribly isolating and very daunting. It doesn't matter how heroic you are, how educated you are, you're still that one person living with a wound. Do we listen and hear? How many of you actually, if you're honest with yourselves, thought about what is it really like? The work I'm doing, the work I'm trying to resolve to give quality of life. But what is it like for the individual? Now this is where I do this. I've got my technology assistant here.
I think it must be about 10 years now that I've had leg ulcers, on and off.
Had the ulcers, it's like 20 odd years now.
I got my ulcers about 3.5 years ago.
He's had a number of them over the years, and probably first one maybe about 20 years ago, but the one that he has currently is the worst one that he's had.
I first got a wound because some lady hit me with a shopping trolley.
I had problems with varicose veins, and subsequently I have had ulcers.
I'd knocked my ankle and it didn't heal.
I don't want anybody to go through this. It's a pain I can't describe. I used to like going to cowboy dances. I just lived life to the full.
She's now feeling that she hasn't got the oomph to go and do those evenings.
Yeah, I suffer with a lot of leakage on both ulcers, on this leg and that leg, which ends up going and seeping through the bandages, etc. And they tend to smell, and it's embarrassing for me. When I'm here at Leg Club and they try to take the dressings off, it's painful, very painful in fact.
It's difficult on a day-to-day basis watching him with the ulcer because he's not as mobile as he used to be. He gets frustrated. I don't think people really understand the pain that these guys are in and the embarrassment.
I have experienced leakage, and it has meant, obviously, having to have a quick change of dressings.
I try to isolate myself away so people don't have to deal with it, it's just me. My husband's really good and he'll pick up what I can't do.
First thing I want to do when it's healed is go to the beach and sit by the sea and have fish and chips and a glass of wine.
If they ever get healed, I would just like to go out with the grandchildren for a nice long walk.
Go swimming. I love swimming. and walking. So as soon as the pain is manageable, I start walking, but then as soon as I don't have to have a dressing on anymore, it's straight in the pool.
Well, I used to like wearing skirts and being able to sunbathe, stick my legs out in the sun, and really this prevents you doing that.
So that's the work of the lower limb. The leg club is a psychosocial model, so we treat the whole person. And these are what some of our leg club members say. We don't call them patients, and I actually dislike the word patient. I think that they're individuals and people in their own rights, unless you're in a bed in a hospital. But you can see I was in a lot of pain and very frightened. The only person I've known with leg ulcers was my mother, who had them for 10 years without successfully healing. And these are real stories from some research we did. And they are actually transcribed exactly as they spoke. I'm sure there's a lot there, so I'm sure these slides will be available to you. But again, these are real people. So the work you do, don't lose sight of that, please. I know what my nerves were like. Nobody knows what having a leg ulcer is like until they experience it. All unique stories, but there's a generic pattern that goes all the way through. By common experiences, they're all saying isolated pain, stigma. Horrific stigma goes on. People will withdraw from society. But also, it's not in our textbooks. No stories are. But they will always tell you what you want to know. Don't you tell them. They're an individual. Work with them and listen and hear, because they'll give you fantastic information. But it's time. And out in a hospital or a clinic, if you can give that one individual with the work Hawkins did on a sense of listening to them with time, it's invaluable. So, the hidden wound, it decreases quality of life and it affects depression, withdrawal from society, mental health problems, to live in pain constantly and dread getting up, or marriages break down because of the odour in the bed. And somebody said to me, my husband said, "You stink again in this bed." That was their very words. So unless we change, unless we do research, unless we bring some hope and quality of life, nothing will ever change. And we must always appreciate the older generation, because you'll all be old one day, and each and every one of you will be a patient in some shape or form. So thank you very much.
Thank you. Thank you, Professor Lindsay, for your amazing work and words. And now we properly start with our first round of questions, and the very first one is for our rector, Professor Menico Rizzi. So, chronic wounds are often seen as a challenge in high-income countries, but what about in developing and emerging nations? How widespread is the problem there? What kind of wounds are most common? And what strategies, both medical and community-based, can be used to improve their care and treatment?
So thank you. First of all, as a rector, I should start with welcoming everybody here in Novara, in our university. So very much a pleasure for us to host you here. But first than that, I would like to say that the movie we just said is very, very intense, and it made me emotional. So, because I don't work in this field, but it was so effective and so well presented that made me thinking even more about the relevance of something which is generally ignored as a medical severe condition by the public. So welcome very much, and congratulations for facing this problem, for putting commitment, energy, and your intelligence and work into this very, very important, as you just saw in the video, medical condition. Congratulations for the first step, because getting European grant is a very competitive one. We all know this, so congratulations for this. And it's a start of a journey that I hope will drive really at the end in providing some help for this extremely impacting in life condition. I'm not an expert of chronic wound. I'm a biochemist, and sadly enough, since I started my rectorship, I almost abandoned active research. I can't do it anymore. I have no time, so thank you very much for inviting me here today, and give me a pleasure to go back to my old passion. So that's very important for me. So I'm in debt with you. Thank you for that. So I've been working in something which is completely different from this field. I'm a biochemist and biophysicist, and I've been worked on malaria and tuberculosis for the last 20 years. And these are considered both diseases linked to poverty. They are not neglected disease anymore, luckily, but they are linked to poverty. And so by talking with scientists, colleagues from Africa, from Asia, from all over Europe, under contexts like this one today, I came to learn that in general, of course, the health assistance and the health system in many of these countries is much weaker than ours. So in general, treatment for patients of any condition in some country in Africa, in some country in Asia, because it's not all equal, of course, is absolutely very far from our standard. So I can imagine certainly that it applies to this condition as well, for sure. And we usually think to Africa or to Asia as burdened by the communicable diseases, by infectious diseases, and we tend to forget. I'm not referring to you. I don't want to be, of course, offensive or anything, but I'm referring to general audience, general public, that the major problem they have is based on infectious disease, which is not true. And of course, many other conditions applies and determine a very bad condition in Africa, as we are experiencing here. So cancer is a problem in Africa, and there is no treatment, not only malaria, although I've been working in malaria, so I should be a scientist that pushes for my own interest in a way, to get funding in that direction, but it's not true. So cancer is a problem. Diabetes is a problem in Africa, very serious one, and diabetes comes with chronic wound. So I imagine chronic wound is actually as much as serious problem in Africa or in some country in Asia as it is is in Europe or in the US. And one of the touching point of the last video is that this condition mainly affects elderly. And I was thinking, and actually when I introduced online this group of scientists, I was mentioning about a problem which is actually a neglected disease listed by WHO as a neglected disease, which is snake bite and venoming. Snake bite and venoming, it's a really neglected disease. It's something that there are about 5 million bites per year, only 2.5 million from venomous snakes. Only 100,000 people die by this, mainly in Africa and Asia, but 400,000 per year are actually chronically injured, and among them, one of the most severe conditions is chronic wound around the snake bite. So, as I said, I'm not a scientist, just read a few papers, and of course, the biological description of that wound chronic is not very far from the one you are actually studying indeed, in reality, but I don't want to comment on this, it's not my place. But I would just like to raise the point that a part of being, of course, a problem anywhere in the world, and of course a problem affecting elderly, snake bite is a neglected disease that mainly affects young people, because it affects farmers, and farmers in Africa are young children or women. So these 100,000 death, or these 400,000 injured chronically, is mainly women and children in Africa and Asia. And this, if we link to the climate change, it will get worse, because more flooding, more raising in temperature, more snakes, more snake bite. Many of the snake bites occurs during flooding because the animals get through the villages. So it's going to get worse with climate change. So it links in the concept of multidisciplinary approaches, as also very well marked in your documentary, becoming a problem which is linked to climate change in this particular case. So, as I said, I'm not an expert, although I spent some time in working on the other field, but in those countries, I think it will deserve attention. Of course, that's by definition. Of course, not in Europe only, in the US only. But there's also sort of a bridge between the elderly and the children in wound injury. And the common point is snake bites. I don't know if anybody actually investigated this one. I Googled yesterday night because, of course, I was expecting this question. That's clear, no? It's not being spontaneously proposed to me right now. That's clear. And so I thought yesterday night and tried to Google something because I read this in the context of WHO because I've been working at WHO for a long time. And these antivenom are included in the essential medicine list at WHO. But nothing is against the wound care, the wound chronic injury caused by them. It's just treatment. So, but now when you show and you highlighted the elderly, which is of course the problem, it came to me that if we talk about elderly, and I'm going to close my short talk here, in Africa, the perception is that we are in the wrong place because it's well known that Africa is the creator of young generation. But this is really inappropriate in my opinion. First of all, because it's not true that there is no elderly in Africa. Second, if we want to prevent a lifestyle, a well-being, and reduce chronic wound in the future in Africa, we should probably involve them in research from the very beginning. So they will face this problem in long term, and they will be involved in what we are developing now to better prepare the weak but they become strong health system in those countries. So I think you're doing something very, very relevant, and in perspective, something very relevant that can be extended to low-medium income countries, and especially in Africa, which is something that I particularly care of. Thank you.
Thank you. Thank you, Professor Rizzi. And now, the next question is for Professor Matteo Santin. Among today's advanced options for chronic wounds, which technologies genuinely change outcomes and which remain experimental, and what barriers can be found along the path that could limit their adoption?
Thank you, first of all, for having me to this roundtable. I think for me to address properly the question and address it for what my expertise is without, going across the border where I can embarrass myself. I think that two important premises to be made are, first of all, that wound management is quite articulated process where some surgical techniques like debridement, options like negative pressure techniques can be applied. I'm not going to comment on those. As I said, I'm not a clinician, I'm not an expert. As far as the biomaterials and the tissue regeneration important issues of wound management are concerned, and going to the point of your question, and following up what the previous speakers have so well outlined, we have also to make a distinction between what is affordable to everybody and what is not in terms of bringing forward innovation. So if you look at the wound management as carried out currently worldwide, a big player, a key player is, in terms of technology, are the wound dressings. And in my previous experience in other projects where I had the
lucky position of interacting with clinicians daily involved in wound management. I learned for the first time, I have to confess, that the application of wound dressings is based on what they call primary dressings, that are dressings that go in direct contact with the wound, and secondary dressings that are applied on the top of a primary dressing. So why do they do that? The answer is that the primary dressing, that sometimes is quite a tool-based material, is a quite rigid mesh, helps with the mechanical protection of the wound, whereas the secondary dressing is basically an hydrogel, which in a way from a biomaterial point of view is much closer to what we are trying to achieve with INJECTHEAL. So, but the hydrogel can be itself used as primary dressing in direct contact with the wound. So why this choice? How the clinician makes this choice? And that is important to understand some of the basic parameters affecting their decision, the clinician's decision. And this is basically mainly the volume of exudate, the liquid coming out from the wound bed. The other experience I've made, and I come to the innovation side of your question, is how they are chosen. So what means high volume, what is... And we conducted a clinical study on clinically available dressing, products that are already on the market. And the clinicians looked for us to patients over 3-4 visits, and we were analyzing the response to the material in terms of inflammatory reaction and so forth. And for us to make our biochemical and cellular study systemic was nothing else but a nightmare, because the clinician was changing the dressing from one visit to the other with no clear other rationale but their experience. So why I'm saying that? I'm saying that because when we talk about innovation, where do we start from? Do we start from the clinician experience, which may differ from country to country? This is another thing that we observed. Or from a mere technology point of view, looking at biology, tissue regeneration as INJECTHEAL aims to do. And the answer probably is a combination of the two. We can't expect to change the practice because in the actual fact, the practice is giving good results. Not ideal, but is saving life, is improving the quality of life of people. So the innovation, going to the point of wound dressings in general, or injectable materials for deep wounds, and that's another important nuisance that we should be taking into consideration, is the complexity of the system, how we can implement at industrial scale with industrial requirements what we have cleverly developed in a lab environment. So it's a scalability, sterilization, and so forth. And that brings me to innovation that is affordable to a wider population, and the elite innovation that we should be careful of when we talk about it. So the affordable innovation, if you look again at the wound dressings, in the last 30 years or so, last 3 decades, what you have are wound dressings that are nothing novel in terms of material. It's just a reformulation of what, and the companies compete with each other, trying to tweak it a bit to make their product differentiated from others. And the other big innovation is the introduction of silver as antimicrobial, silver nanoparticles as antimicrobial agent with some pros and cons that we don't have time to discuss. So what I'm trying to say is that for decades, for 3 decades, the innovation has been stalling, and what in essence we have is a reformulation of existing products. And that brings us to the innovation at research level and of my own experience, linking it to what I said it is not affordable for many. We have developed in the past at the University of Brighton, and then with my company Brighton Wound Care, a hydrogel based on, derived from defatted soya flour that we can reconstitute in the form of gel. And we have established last June a company in Nairobi in Kenya with this particular intent to exploit the technology where people are likely not to afford something that is more costly, more expensive.
Maybe the common knowledge and tradition they do have in treating these.
Exactly, and I was humbled. I had a lesson from my Kenyan colleagues, not only because of their expertise, but also because I saw we had very strong, at the moment, very strong link with the Ministry of Health of the Kenyan government for non-communicable diseases, and they have big problems of road accidents, violence, either domestic or criminal or guerrilla at the border with other countries. They have the equivalent of our Uber. For them it's motorbike, and they have a lot of car accident, motorbike accident. So the problem of wound management on the top of increasing diabetes and other cardiovascular conditions makes very relevant for them. So with the soya bean, going back to innovation, soya bean, we have proven in vitro and in vivo in a non-healing skin model showing regeneration properties. And that in a business plan that we have recently drafted, completed, we can prove the scalability, we can prove the cost-effective production and use of these materials. Then we come to INJECTHEAL, where our ambition is to assemble a number of components, which in effect can treat not all the wounds, because probably it will be a final expensive product, but very challenging wounds who can save money to the national insurance, national health system in the long term, which are the deep wounds. So the balance in terms of innovation, I conclude with that, is to consider the affordability, the industrial feasibility, but not being necessarily stuck in a rut of what is imposed to us by the market, in consideration of the requirement of other geographical areas where economical conditions requires smart solutions that are also affordable solutions. And for us as researchers, I think our daily effort and thinking should be in terms of what is the compromise which inevitably we will have to face between high reputation and high skill and sophisticated technology, which enhance our reputation, and what is really affordable to as many people as possible. So I think that recapping existing innovation in inverted commas, wound dressings reformulated with silver, antibacterial, or innovation affordable to others with gels that can prove some level of efficacy at affordable costs. And then serious deep wounds where inevitably more expensive, technologically complex solutions are required, but can be transparently managed from an economical point of view. Thank you.
Thanks a lot. And now it's Professor Raoufi's turn. He is a scientist and an entrepreneur, and I'd like to ask him, which are today's most promising technological solutions for chronic wounds, and how can industry drive their development, cost effectiveness, and global accessibility?
Thank you so much for the question, and thank you, Lia, for inviting us here to be here. In line with our previous speakers, I wanted to mention that the chronic wound is like silent and hidden epidemic that affecting millions of people in entire of the world. And this reduces a lot of quality of life, as our colleague mentions here. And when we look at the market, we will see with all of the attempts that a lot of people did, still we don't have a dedicated product for some type of the wounds, and most of the product exists in the market are more focused on the management of the wound, to keep the wound clean and actually protected, not to doing the regeneration. Of course, we have some product in the market that they actually do the regeneration, but they are very, very expensive, and it's not applicable for everybody to use it. Critically, when we, in line again with the Matteo that he mentioned about the tunneling wounds, critically some type of the wound is still we don't have a good product to use it, and everybody can use that. Like deep tunneling wound, still when you go to the market, you cannot find a product that everybody entire of the world can use that. That's why I will see the clear space that we can work on the complementary technology to bring some product to the market. As an industrial aspect, I wanted to, if we wanted to make this solution in real, we have to be very strategic and selective. Complex platform is not useful. We need the simplest clinically viable platform to work on it, validate it, and step by step, as we mentioned yesterday and today, add some things on it. But when few gate is open, first gate is to check the feasibility of the regulation, manufacturing at the scale, and the main part, as the colleague mentioned, is a clear value on the health economic systems for the economic part. At the same time, industry should build the translation to the DNA of a lot of projects. This means that patients and nurses and clinicians should engage with the project from beginning, that we target exactly what they need at the end to use it. Otherwise, this is not applicable. We don't want to just improve the efficacy of the product. We wanted to demonstrate some things which is cost effectiveness, and also decrease the number of the day that the patient should stay in hospitals, less amputation, and of course, actually less overall burden on the health systems. This means we develop the robust pathway to do few works, protect the IP, validate the GMP process, and of course, secure the raw material supply chain. And we have to build the business model that can combine premium pricing for high income market and modular one, or the low cost version for the other lands, that everybody can use that one. If I wanted to summarize my talk, I will say that in industrial aspect, we are focusing in a lot of things: regulation, end user, IP protection, and scalability for the manufacturing. But industrial are looking really to the product that can truly do the wound healing, not more focusing on the wound management. If you go to the market, you will see more than 700 products that most of them, they do just management. As Matteo mentioned, silver is one of the things that now came and solve a lot of problems regarding the antibacterial and antibiofilm problem for the chronic wounds. That's why industrial always are looking for the product that truly do the wound healing and regenerating, and of course will be applicable for most of the people entire of the world. Thank you.
Thanks a lot. And now, in the last phase of our roundtable, we go deeply into INJECTHEAL, so I would like to give the word to Ellie to illustrate the proper phases of the project and the achievement till now. So the stage is yours.
Thank you so much for including me in this roundtable. Actually, I'm not an expert, just like the rest of the colleagues here. I would like to just, maybe the presentation, if there's one.
Sì, comunicazione per la regia, un piccolo cambio di programma. C'è già la presentazione di Ellie, che è l'ultimo PowerPoint. Grazie.
Basically, everyone is inside this consortium and you're all aware of how the INJECTHEAL became a project. So what I want to say is nothing new, it's just like a wrap-up of what it was said and what it was emphasized. It was very perfectly explained from Ellie, Matteo, and Mohammad. And I think the point here is that we would like to innovate and have a product that is, in this case, injectable, because when it comes to the problem of changing all the time the primary and secondary wound healing dressing, that's something that if we could avoid in certain kind of wounds, then we would inject the product and then protect it with the dressing. So it's going to become sort of complementary to what already exists in the market instead of competing with them. And obviously here the focus is not only on the wound management, but rather than the healing phase of the wound. So we want to have a unified product that could deal with the antibacterial infection, it could deal with the inflammatory phase, and eventually also help to heal the wound. So the whole consortium came together to come up with such product. But I think the uniqueness of INJECTHEAL is that from the beginning, we tried to include, for example, Trinity College Dublin is going to do the ISO test that is essential for the regulatory phase if this is about to succeed. So we keep in mind that it's part of it, it's a fantastic, it's a very innovative scientific project, but it's also, we are looking forward to make the product to the market eventually. And the inclusion of, for example, leg club to see what is the prospect and what is the experience of the patients that they suffer from this. And not only the scientific part of it, but even emotionally. Like, I don't know, I don't think it's going to be changing the dressing. It's going to be something negligible to just say, from the patient. So if we could avoid them some unnecessary pain and suffering, this could be something to look forward to. And so we think this consortium is unique in that sense that we are going to combine different aspects. We're going to talk to clinicians from the beginning. If they are against using antibiotics, we want to know it in advance, which dosage they want to consider to use it. So, and the socio-economic analysis that in Spain they're going to conduct this study. So, as a whole, we are doing our best to take everything into consideration, from feasibility, from the prospect of the patients, from the clinicians, and then there is the scientific part of it, that here in this schematic figure you can see that we are trying to deliver the very functionalized dendrons, that they are functionalized with the, let's go to the next slide maybe. it doesn't go to.
Prossima slide,
Okay,
grazie.
so it's built in a strategic way that we start from a foundation, which is the injectable hydrogels, as we said, to have a product that doesn't rely on the dressing and changing the dressing all the time. And we have these dendrons as a foundation of the functionality of what we want to provide in this product, so that we could play with different, from the antibacterial effect to the anti-inflammatory effect to the pro-angiogenic factors, all of them through these dendrons. But then the whole thing, once that it wants to come together, we need to consider a selective process to be able to find the simplest formulation that could eventually make its way in a feasible way, not only economic, but like a feasible way into the market, and not just staying as a scientific fantasy. And thanks everyone for being here, and that was, yeah, that's it. That's the wrap up, basically.
Thank you. And now, before closing, I will give again the word to the Rector Rimondini, just to remember the importance of all the partners of the consortium and to thank them before thanking all of our guests and, of course, all of you.
Thanks, Simone. Yes, I would like to remind the importance of the international collaboration. That is absolutely fundamental for the progress, for our scientific development, for the social development, and even I add for the maintenance of democracy. So I think that there is something really deep and important after this. INJECTHEAL get together many partners with a different expertise. It is very important to have a multidisciplinary approach to develop something effective. Coming from different countries in Europe, and that I would like to personally thanks. And now I namely make an hint to all of them. The coordinator is the University of Piedmont Orientale. UCOR that is providing a great support in communication activities. Acribes from Austria that provide preclinical experiments, and it is a company very, very focused on wounds treatment. University of Siegen from Germany that are specialists in drug delivery system. University of Brighton with a strong experience even in tissue engineering and regenerative medicine. Tissue Click, that is a company that helps us to make our innovation something real, something that can be used and maybe feasible. So the Trinity College for the preclinical evaluation that provide even expertise in regulation. Polytechnic of Turin that are at the basis of the development of the hydrogel. Ioanneum Research even for in vivo studies, so great expertise. Economical expert from the Consiglio Superior de Investigación de Ciencia that help us to understand if the item, the product that we are developing is something that can be sold. Leg Club Foundation that help us in making something friendly for the caregiver and for the patient. That is very important. And finally, la Scuola Universitaria Professionale della Svizzera Italiana, which provide the ICT evaluation of the product, help us to develop experiment in silico that is a very, very modern approach for the science. So I would like really to thank all the partners, because all of them are crucial and they are contributing in a great manner to the success of the project. Thank you so much.
Thank you. And thank to everybody, but before of all, thank to our guests, Ellie, Lindsay. Applause. Mohammad Raoufi. Our Rector, Menico, Rizzi. Lia Rimondini. Matteo, Santin. And the Lamb, Sharifi. Thanks again to everybody. Have a nice day.
Thank you.
Thank you for inviting us here. It's a pleasure. It's a happy day.